Yeah, we can see it. Thank you.
Okay, great. So hello, everyone. Back for more part 8 today. So let me see. Can I cycle through these? Okay. So we've done all the ones in red boxes so far. Today we will cover the risks of atypical femoral fractures and the risks of osteonecrosis of the jaw when patients are on bisphosphonates and denosumab, so anti-resorptive treatment. Okay. So an atypical femoral fracture, also known as AFF. So what's the mechanism whereby this happens? So essentially, the way I say to patients is that I say to them, when I came to get you from the waiting room, or in the old days when we used to see patients, a little strut in the cobweb of my bone, that's the trabecular or cancellous bone, may have broken. I didn't break my leg, but that little strut broke. My bones are awake, that gets repaired gradually. In someone who's on a bisphosphonate or denosumab, where you have reduced bone remodeling, that strut does not get repaired. So after a prolonged amount of exposure, normally several years, several struts can line up and create a weaker area in the bone that is therefore prone to fracturing. Now, when we walk, most of the force goes through our mid-femur. Okay, and that's why the struts tend to be in this mid-femur, and this is why it's atypical, because it's not necrofemur, it's below the lesser trochanter and above the supracondyle of the knee. Okay, so that's the essential mechanism that causes an atypical femoral fracture. So it's suppression of bone turnover, so these micro defects do not get repaired. And a similar phenomenon is present in osteonecrosis of the jaw. So osteonecrosis of the jaw sounds worse than it is. Okay, so it basically means exposed bone in the mouth that doesn't heal after 8 weeks. Okay, it's certainly better to have that than to break your hip, number one. Secondly, the jaw is one of the most traumatized bones in the body because you're chewing on it all the time. It's also prone to surrounding infections due to gum infections. So these insults can cause a similar lack of healing, similar to the lack of healing of the struts in atypical femoral fractures in the mouth. So I hope that makes sense. So atypical femoral fractures, often the patient will complain of prodromal pain, so an ache in their groin, classically. So every time you see a patient who's been on long-term or even short-term bisphosphonates and complains of groin pain, then think to image the hip. And I'll tell you why. They may not have broken it at that point, but there may be some warning signs. So I advise patients to report any unexplained thigh, groin, or hip pain whilst they're on these anti-resorptive treatments, which downregulate bone remodeling. Send them for an X-ray. So this lady, she was one of my patients. She had a, she was one of my patients much later on, but she had surgical fixation, as you can see here. Okay, so in most cases, this requires a pin, okay, or a nail. So what is the definition of an atypical femoral fracture? This was published in 2014, was a revised case definition. So here are the major features. So you need 4 out of the 5, and there's also the minor features, and you don't need any of those. But essentially, it's associated with minimal or no trauma, number one. And here's a picture of it here. So it's substantially transverse, so you can see a cross, transverse, but can become oblique as it crosses the femur. As you can see, it became oblique as it went across. The complete fractures extend through both cortices and may be associated with a medial spike. You've got the medial spike here. Okay. The fracture is non-comminuted. It's a word I always find difficult to pronounce for some reason, comminuted. So yes, it's in 2 pieces, not multiple other pieces. and there's often localized periosteal or endosteal thickening of the lateral cortex sometimes. So you need four of the five. So this one meets all the criteria. And you don't need any minor criterias, but sometimes you can spot early signs when there's an increase in cortical thickness of the femoral diaphyses, some prodromal pain, so this dull or aching pain in the groin or the thigh, which should alert you to image. And sometimes they can have delayed fracture healing. There are other risk factors for atypical femoral fractures. Unfortunately, steroids is one of those. So steroids can give you osteoporosis, meaning you want to then treat them with anti-resorptives, meaning now they've got two risk factors for atypical femoral fractures. Other risk factors include female, Asian ethnicity, and more than 3 years of treatment. So it's a cumulative increase in risk. So is there anything else? I don't know, I can't see the chat. Is there anything else you're concerned about when you look at this X-ray? Let's see if I can see the chat.
You can see it. You can see it at the top. If you,
yeah, I can see. I've got the chat. Is there anything else?
there's nothing else yet.
If anyone wants to type anything, what my femoral artery? I can see injury, contralateral periosteal thickening. So exactly right. So if you look at the other side, do you see this is the beaking? This is the periosteal thickening, and this nips in here, comes out here, and on the other side, that's called the beak. And this is the start of a fracture. So when you see this, you need to worry, and you need to think about sending to orthopedics, who will probably do an MRI to see if there's actually any clear lucency there to suggest a fracture that is starting to form. Okay, so always when a patient has a atypical femoral fracture, make sure you image the other side as well, because this is what can happen. So there you go. This patient had her second atypical femoral fracture, and we presented this at BES a few years ago.
So should they have put a bit of metal in there beforehand, or what?
Okay. Well, the normal process is you will do an MRI to see if there's any clear lucency. You stop the bisphosphonate, then you will probably, in most cases, put a nail down, intramedullary nail. But the patient came to me after having had both of these, and I think the patient had only been actually on 4 years of alendronate at that point. She was Asian. So atypical femoral fractures. So there's high risk of bilaterality. So always look at the contralateral side, as there may be an impending atypical femoral fracture. So they don't only occur at the upper part of the femora. So it's always below the lesser trochanter. Remember, that's the area that most of the weight goes through your body. So that's the area that's susceptible to these micro trabecular breaks. So here you have an incomplete one. You see the beaking again here on the knee, on the right, I think it's above the right knee, and then a complete one here just above here. Okay, so anywhere along the femora up until the condyles is the sites. Okay. In terms of management, so in these patients, you really need to be basically referring it to a specialist clinic, and obviously orthopedics. But the basics of the management are basically, obviously you would stop the offending bisphosphonates or denosumab. And then depending on if they have high risk of more fractures or whether they have low risk of more fractures, there are different approaches to management. Essentially, if they've got high risk of fractures, you still want to try and prevent further fractures. In some cases, you can use teriparatide, even in patients who haven't been operated on. And there is some weak evidence that teriparatide may enhance bone healing. It would make sense because it stimulates bone remodeling. So it would make sense that it would improve it. However, the studies to date have not clearly shown this, but it is with very small N numbers, and there's no randomized controlled trial of teriparatide versus other treatments for atypical femoral fractures. It's more case reports. If they'd been non-operated on, the other options, you've got romosozumab and other medications, but basically nothing that's anti-resorptive, nothing that will suppress. If they have been operated on, you may consider putting them also on an anti-resorptive because at this point they've obviously got metalwork to support their skeleton. If they've got low risk of fractures, there is some evidence again similarly for teriparatide. Again, no RCT data, but there is occasional data, and I've used it once. And then if they have been on denosumab, you should give them a short course of a bisphosphonate. That's to prevent the rebound increase in bone turnover markers seen after denosumab cessation, which I will cover in a future session. But the ultimate thing, atypical femoral fractures, discuss it with a specialist in endocrine bone, what to do, and normally you would refer the patient to that clinic. So here's our interactive case. So a 76-year-old woman attends your clinic and is very anxious. She has just read in the Daily Mail that bisphosphonates cause osteonecrosis of the jaw. She would like to stop her alendronate immediately. So do you agree there's a very high risk of osteonecrosis of the jaw and she should stop her alendronate? Advise that switching to denosumab would be an option because it doesn't cause ONJ. Inform the patient that more likely to get run over in the street than get ONJ. Advise her that bisphosphonates do not cause ONJ, or advise switching to risedronate. So I think, Kareem, can you go to the Mentimeter?
Yeah, we're all voting. And if you got to the end, because we went to the end, you might have to redo your phone. But I'll put the number is, they're coming in actually. 8 people have voted so far. So the code is 339812. Do please vote. And I'll share that screen in just a couple of minutes. So if your phone hasn't got it, if you just press enter again on your tool on the bar at the top, the question will appear. Okay, I'm going to share the screen because I can see some answers all coming in.
So I stop share, and
then I will.
So we've got a 76-year-old woman, anxious, reads in the Daily Mail that they cause jaw problems and she wants to stop her alendronate.
There we go. Can you see that?
So the majority, so if we go through the answers, the correct answer is C, which 28 of you have got, and I'll show you the data on that actually. High risk of ONJ, so answer A is incorrect. So the risks of ONJ are approximately 1 in 1,000 a year, something like that, okay? Very similar to the risks of atypical femoral fracture. Maybe atypical femoral fracture is slightly more common, but it really depends on the study and the duration of that study and the exact drug used for it. But I normally quote 1 in 1,000 to patients per year.
Yes. So that answer, it doesn't say and continue alendronate. Is that what we should do? I'll stop sharing.
Yeah. So so yeah. Okay. Let me share. So, share screen. Okay.
Yeah, that's it.
So for B, denosumab will also cause ONJ and atypical femoral fractures, similar in result, maybe slightly increased risk because it's more potent anti-resorptive, but no one's done a clear head-to-head to show difference. Inform the patient they're more likely to get run over in the street than get ONJ, so that's the correct answer, and you should continue the alendronate because of the benefits to the patient. Advice that bisphosphonates do not cause ONJ, wrong. Advice switching to risedronates, no evidence that they're different. Oral bisphosphonates have a different effect on atypical femoral fractures. Okay, good. So what are the risks of atypical femoral fractures and osteonecrosis of the jaw? So this was a paper in 2016 in JBMR, which quite nicely summed it up, and I actually carried it around with me when I go to clinic and show patients sometimes when they're concerned about these rare side effects. So here we have atypical femoral fractures and osteonecrosis of the jaw. And these are patients treated with bisphosphonates. So 30 per 100,000 is the incidence. And for osteonecrosis of the jaw, 0.2 per 100,000 is the incidence. Now, if we look at pedestrian injury, so you can see this is 54. This is in America. I don't know, some of the videos you see of them driving might make you more worried. Murder is also more likely than osteonecrosis of the jaw. That's in America again. Then stroke and breast cancer, you can see the risks here of a stroke, the risk of a breast cancer, also when you put them on aspirin, and the risk of bleeding on aspirin as well. So you can see there's a lot more risky things than atypical femoral fractures and osteonecrosis of the jaw. And crucially, these are the risks of the fractures. You can see the big, solid, tall bars for hip fractures and wrist fractures, with or without treatment. So the basic concept is that an oral bisphosphonate will result in up to 45% risk reduction in future fragility fractures. An IV can be over 70% risk reduction in future fractures. Okay, so when your risk may be something like on fracs, it may be 6% a year, 6% over 10 years, it goes down to around 3%, something like that. So you've got a 3% risk reduction. But your risk of these rare things is present, but is far counterbalanced by the benefits. So the message today is atypical femoral fractures and osteonecrosis of the jaw are real, but the risks are very small. So the numbers needed to treat has been worked out, and approximately, so bisphosphonates prevent approximately 1,200 fragility fractures for each AFF that they cause. In general, the risks are outweighed by the benefits of treatment. So the approximately 0.1% risk of osteonecrosis in the jaw is compared to a significant reduction in hip fractures, for example, a slightly greater reduction in vertebral fractures when patients are on bisphosphonates or denosumab, and you can see an equivalent drop there. So it makes sense to delay starting treatment with these drugs, however, until a patient has completed any urgent dental work. And I often say to patients, go to your dentist, ask them, is there any dental work you would envisage me needing in the next few years? If so, can we do it now? And then once everything's fully healed, then they can start their medication. Sometimes it's difficult to assess someone's dentition. We're not dentists. But you can get an idea by asking the patients essentially if they have any wobbly teeth or any significant dental history. You can get osteonecrosis of the jaw if they have dentures, don't forget, because it's just exposed jawbone that can come through. Okay, so they need to make sure they have good fitting dentures. If a patient does have an AFF, then always image the contralateral side and refer to a specialist clinic for ongoing management. Obviously, refer them to orthopedics. The risks of atypical femoral fracture do decrease very rapidly on cessation of the offending drug, and that's why we do have the bisphosphonate holidays, which I spoke about on our last session. That's just basically to reset the bone, let the bones wake up a bit, repair the micro defects, and then you go again with treatment if required at the end of their holiday. Good. Thank you for listening.
Okay, thank you very much. I'm going to put the QR code up for people to... Okay, Zenat Barnett has asked you, how long a holiday should we go on?
So there's no specific guidelines. You should normally be monitoring patients between the guidelines normally say 1 to 3 years after stopping. But my practice is to for risedronate to wait 1.5 years, for alendronate to wait 2 years, and for zoledronate to wait 3 years. and that equates to the potency and the affinity for each of the different bisphosphonates for bone.
So the main one is 18 months for alendronate, is that right?
No, alendronate 2 years.
2 years.
Okay. 2 years, but you in some cases you may want to check earlier at 18 months if you're very worried about this patient and you're not very you're reluctant to stop. Like for example, a patient who's had 10 years of alendronate who should really now have a bisphosphonate holiday no matter what, but has really bad bone density or fracture profile, and you want to therefore minimize the duration of the bisphosphonate holiday. Don't forget they are protected during this bisphosphonate holiday because these the bisphosphonates last in the bone for several years. You know, you can get effects beyond 5 years. Post-mortems 10 years after a dose, and you'll find bits of a bisphosphonate still in the bone, and they stay in the bone, and then the osteoclasts go along and chew up that bisphosphonate, which then reduces its activity.
So basically, the benefits are there for years and years as well.
Yeah. So don't be scared. So when you tell a patient we're going to stop your bisphosphonate, you say to them your bones are still protected, but we let them wake up just enough to allow repair of the microarchitectural defects, and then we go again with the reinitiation of the full dose later on if needed.
Okay, an important question on the chat that you can see, but I'll read it. If the bisphosphonates cause the fracture, can we use denosumab, and when do we stop that? Can we go back to bisphosphonate?
Is bisphosphonate caused it? So they both will cause atypical femoral fractures by the same mechanism.
The answer is not to switch to bisphosphonate.
No.
We should not do that.
No.
What would you do then? So I've stopped my bisphosphonate. Do I just stay on nothing for a year and a half?
It depends on your risk profile. If you're really at high risk of future fractures, then we need to look at exactly what to do. It depends on a lot of factors, like is it healing your atypical femoral fracture? If it's healing well, then you might be okay to trial something once all the micro defects have repaired.
Yeah, but not denosumab, because that's the same mechanism. It needs to be a different reason, like a.
Then we use teriparatide. You've got your SERMs and romosozumab in future as well can potentially be used. They work slightly differently and less suppressive on bone turnover. And you've got teriparatide, which obviously is stimulatory on bone turnover.
Okay, so one suggestion here is vitamin D and calcium during the holiday.
Yeah, so every patient in my clinic, unless they are having more than 3 portions of dairy per day, 3 or more, is on calcium and vitamin D supplementation. If any of you have time and you go onto an online calcium calculator, you'll probably find that you are deficient in your recommended daily amount of calcium. So it makes sense. And all the trials have been performed in patients who are also on calcium and vitamin D. So it's essential. You need the building blocks physiologically anyway for these drugs to work, and that is calcium. And to absorb your calcium, you need your vitamin D. So it makes sense.
Okay, and there's one other question on about. So NICE says keep going beyond 5 years if you really must, because the benefits are so good. And then I think the question is really about when to go on holiday.
So the standard, I think we covered it perhaps on. You can have a look at the last session I did. But essentially, you've got 5 years orals or 3 years IVs. Then you need to make a decision whether you continue, and that depends on the age of the patient. So, age over 75, if they're on steroids, if they've got a hip T-score less than -2.5, or if they've got an incident hip or vertebral fracture, are the main parameters that would make you, because these are the high-risk patients, and so this would make you want to continue the treatment for a further 5. So that would be 5 + 5 or 3 + 3 for the zoledronate, because for them, the risks of atypical femoral fracture and osteonecrosis of the jaw are still too small in comparison to their super high risk of further fractures.
Yeah, I mean, that's the key message. We should mostly keep going. Okay, there's a question. Can I just ask, you meant, whoever written that, Valmiki, you mean hyperparathyroidism? Yes, hyper. So can you see the question, Alex?
So out of topic. Yeah, if a patient has primary hyperparathyroidism and has osteopenia in the wrist with a serum calcium, would you recommend bisphosphonates? Well, I mean, here you've got, there's a lot of things obviously to consider. Have they got symptoms? And then already, you've got the fourth asymptomatic hyperparathyroidism guidelines, which basically say that if your calcium is above 2.85, you would be a candidate for surgery.
I think surgery is the primary treatment for this patient. I know we haven't got a background. Maybe they're too old for surgery or whatever.
Yeah.
But yeah, the primary treatment is surgery. But there's a question about, would you recommend bisphosphonate? Let's say the patient was not fit for surgery.
So yeah, you can. So I've got a couple of patients who I've got on cinacalcet for symptoms, bring their calcium down, plus denosumab for bone protection, and also to help as an adjunct for bringing the calcium down. So therefore you reduce the end organ damage. So you can use bisphosphonates. It's not going to be very effective in patients with hypercalcemia. Denosumab is more, so there was an Italian study, I think came out last year, where the calcium was reduced by 0.09. So essentially 0.1. Okay, so if it's 2.9, it'll go down to 2.8 if you've got a patient on denosumab. It will also protect them, however, very well from the worsening bone density through the rank ligand pathway, which also is what the hyperparathyroidism eats away at the bones using that pathway as well. So it's different to the bisphosphonate pathway. That's why denosumab works better.
So you're saying denosumab rather than, because the question about bisphosphonates, but you're saying use denosumab instead?
Yeah, it depends. It depends. You need this patient that needs to come every 6 months for their injection, and so it needs to be reliable. If they're not fit for a surgery, you may say, well, are they fit to come every 6 months for denosumab? Because if they miss or delay significantly a denosumab injection, you get this dreadful rebound increase in bone turnover markers and risk of fracture, which I will cover in a future session. So in this patient, you may just put them on, give them a shot of zoledronate. That'll protect their bones well for a couple of years, and then maybe some cinacalcet if necessary.
So you put that ahead of, I want to be clear on this, denosumab. You give a zoledronate dose instead of.
If you're saying that she's not fit for surgery.
Yes.
So, but if it was you, for example, and you've got hyperparathyroidism, and your calcium is 2.9, and for one reason or other you can't have surgery, but you're you're well otherwise, then I would probably say denosumab plus cinacalcet.
Instead of, I would choose personally a 1 dose of zoledronate.
But it's not going to bring down your calcium at all.
Yeah.
So we've got some patients who are just on denosumab. The Zol will bring it down temporarily, but it escapes very, very quickly in this situation. Yeah.
So there's two questions, then we should stop. There's a question about, again, primary hyperpara. Let's say they've got established osteoporosis, but are cured by surgery. So they should then start to have an increase in bone density, which may be a bit disappointing, I guess. But would you then add an oral bisphosphonate on top of surgery?
So my usual practice is to wait around 2 years post-op for the bones to recover as much as possible. The thing, so you'll find some studies will say up to 5 to 10% improvements in bone density after parathyroidectomy. However, in reality, we don't really see that, and we definitely don't see that at the wrist. And it's quite complex, the reason why we don't see that at the wrist. The wrist does get stronger, but the bone density doesn't. So essentially, I tend to wait about 2 years, and if they're 2 years, they're still very high risk, then I would give them a bisphosphonate or whatever is appropriate at that point. Yes. Would you prefer denosumab over bisphosphonate in? So yeah, it depends on the patient if it's denosumab or bisphosphonates. Denosumab, you need to be coming for your injection every 6 months. There is some calcium control. There is better bone protection. But bisphosphonates, once a year or even every 18 months dose of a bisphosphonate would be adequate for bone protection in some participants. Does denosumab have a more sustained calcium lowering effect? It's more potent, denosumab. And you'll see it depends on, no one's done like a duration of effect trial, but the oncologists can give both every month, and I think denosumab is slightly superior to zoledronate. Zoledronate versus zoledronate. So zoledronate will be more potent so zoledronate reduces your fracture risk by up to 70% in your spine.
This is one dose per annum, yeah?
Yeah, zoledronate once a year, yeah.
Compared to alendronate once a week.
Once a week. Alendronate is about 45% risk reduction for vertebral fractures. So zoledronate is more potent.
Okay, listen, can everybody click their QR code, please, and give us some feedback? We really need the feedback. And then you get your certificate as well. I know it's a bit slow, but we'll do it in about a month or so. But if you could do that today, that would be really helpful. There's a question about tachyphylaxis in terms of calcium lowering, Alex.
No. So tachyphylaxis, you're suggesting if you give repeated doses of denosumab, does it eventually escape? And the answer is no, because that is the process by which they have the hypercalcemia. So you're just blocking that process.
Okay, and one other advert, by the way, I did